पहली स्लाइड पे है बाद में मसला आता है सब ये बहुत ही
म्यूट म्यूट कर लें अपना। चले
तो जाना है
म्यूट मैंने किया है, ये म्यूट है।
यहाँ से कर रहे इसको साउंड ऑफ कर दें Bismillahirrahmanirrahim. My name is Dr. Osama Chima. I'm working as a trainee registrar in the Department of ENT, Sheikh Zayed Hospital, Lahore. I welcome you all to our live academic webinar, which is done under the organization of ENT Insight, uh, which is the brainchild of our head of department, Dr. Sarfraz Latif. I would also like to welcome Professor Solat Sarfaraz, who is the head of Department of Radiology in Sheikh Zayed Hospital, and she'll be also providing us some insight regarding the assessment of dysphagia. Thank you, ma'am, for joining us. And we have also in our panel Professor Tahir Rashid, who is the head of Department of ENT in Lahore General Hospital. And thank you, sir, for joining us. And he'll be also giving us some useful insight on the topic. So I would like to start my presentation. The topic of today is assessment of dysphagia. Imagine not being able to swallow a simple glass of water. That is a reality for millions of people suffering with dysphagia. About 22% of population above 50 years suffer from dysphagia. Let's talk about what is dysphagia and what causes dysphagia and how are we going to assess dysphagia. So by the end of the presentation, I would expect you all to be fluent in defining dysphagia and odynophagia, developing an approach to rule out the different differential diagnosis of dysphagia, and also to compare the different causes, and in the end, making a detailed diagnostic battery when dealing with the patient who has difficulty in swallowing. So dysphagia is basically comes from a Greek origin where dys means disordered and phage means eating. So it is defined as a difficulty in swallowing, which can be for solids, liquids, or both, and sometimes non-organic in nature, presenting with different grade of severity. What are the related terms that we also know and we'll be discussing is a sensation of sticking or obstruction. Then there's aphasia, which is the complete esophageal obstruction, and odynophagia, which is basically painful swallowing. So let's talk about the cloud concept of dysphagia. Cloud concept, as you all know, is basically a pictorial representation of a word and all the words linked with it. So dysphagia basically comes in the symptoms and sign in ICD-10, and it is classified as a condition in its own right. So it can occur in all age groups, and we'll be discussing it in detail. So, as ENT surgeons, we all know the basic physiology of swallowing. So, that's not the main domain of our topic. So, let's begin with the pathophysiology of dysphagia. So, whatever structures that control swallowing, such as the nervous system, mainly the vagus nerve, then the oral cavity, tongue, pharynx, the musculature, and the sphincters, if any of these get involved, then we can have patients presenting with dysphagia. It can either be a structural, functional, or a motor disorder. So let's look at this vagus nerve. It has a large course, and you can see how it is basically supplying the esophagus and forming an anterior esophageal plexus. And this is the main innervation of the musculature and the sphincters, along with the myenteric and aortic plexus. So let's talk about mechanical dysphagia. Wherever there's an obstruction in our channel, that would lead to a mechanical dysphagia. It can be either due to a large food bolus, either narrowing of the esophagus that may be inflammatory, developmental, there can be a stricture or a neoplasm, and then there can either be a mass such as retropharyngeal, mediastinal, that is compressing the esophagus and causing the symptoms of dysphagia. Now, the motor dysphagia basically can be divided into either there's a disease in the striated muscle or in the smooth muscle. So, when the striated muscles are involved, it can either involve the upper esophageal sphincter, the upper esophagus pharynx. Either a CVA can lead to this disease. And when it comes to smooth muscle, we have the mid and lower esophageal sphincters and achalasia, because the change in musculature in the esophagus is developed that way, that the striated muscle has a bigger content in the upper third, and then as we move down, the smooth muscles take over. So another way to classify dysphagia can be based on the location. You can see that either the pharynx is involved, or it can be esophageal, then it can be esophago, gastric, and in the last it can be paraesophageal. So these are the different locations. So now, being in OPDs, assessing such patients, what should we look in the history and examination? So we should start with what kind of food gets stuck, and what is either there are liquids or just food or both. So then we should also distinguish oropharyngeal from esophageal dysphagia at the first instant, so we can pinpoint the diagnosis. What are the important points in history? The important points are the onset, duration, progression, severity of symptoms, type of foods, and the alleviating or aggravating factors. Age is quite specific in terms of different disorders. In children, we usually see foreign body and congenital malformations making up most of the dysphagia cases. In middle age, we have the reflux esophagitis, the hiatus hernia, anemia, achalasia, or the globus syndrome. In elderly patients, we usually see malignancies, pouches, stricture formation, or motility or neurological disorders. So, how to differentiate between the oropharyngeal and esophageal phase? We see that in oropharyngeal dysphagia, there'll be a difficulty in the preparing and transporting the bolus through the oral cavity, and the initiating of the swallow will also be affected. The patient can present with aspiration or nasopharyngeal regurgitation. In esophageal dysphagia, the patient will complain of food sticking in their lower throat, neck, or either there'll be some retrosternal or epigastric discomfort. So the sign and symptoms also differs. In oral, there'll be pocketing, there'll be leakage, the seal of the lips will not be maintained, the bolus formation would either be slow or it will be poor, there'll be delay in swallowing, while in the pharyngeal, we'll see that there's coughing, there's the throat clearing, the patient will present with a wet, gurgly sound, and then the patient can choke, and you can see some watery eyes in these patients. The associated symptoms can be regurg, there can be odynophagia, hoarseness of voice, and frequent chest infections due to aspiration and coughing, choking after eating. So these are basically all the signs and symptoms summed up in this picture that we have already discussed. This is what we should focus on in the patient that comes with dysphagia. Now, talking about a serious concern is Aspiration. That's why we are really concerned about dysphagia. The old patients who have motility disorders and who have frequent dysphagia episodes, they'll come to you with aspiration pneumonia, and that is a very serious condition. It can pose a serious threat on the and cause a respiratory compromise. So, what will be the signs of symptoms in these patients? You will see that there'll be secretions coming out from the nose or watery eyes, then there'll be a change in the breathing rate. They'll attempt to clear their throat. The most common and most important one is the gurgly or wet sound. That is also done in the bedside swallow test that I'll discuss in my next slides. So, the physical examination of the esophagus is not easy because it's a deep seated structure that does not lend itself to a direct assessment. However, there are a few tests that we will perform to look at it. But first of all, we'll need a detailed and accurate history, which is basically the mainstay of clinical assessment in patients that present with dysphagia. So, talking about the clinical examination, it should be a complete head and neck examination in patients who have dysphagia. So, first of all, we'll do an inspection of the oral cavity, oropharynx. Then we can do indirect laryngoscopy, nasopharyngealaryngoscopy. We must examine the cranial nerve for look for the movement of tongues, gag, cuff reflex, hoarseness, because these are the contributing factors toward dysphagia. Then we should also examine the neck nodes because, as we already discussed, that the malignancies of head and neck also present with dysphagia. The baseline and journal workup make up the tests for any disease. So we look for the baseline test to look for anemia. Then we should look at the ESR and CRP if they are raised in malignancy. And then we should also look at the LFTs, RFTs along with the serum calcium to look if the nutrition is impaired. And then we can do the TFTs for any malignancy of thyroid. So the tests that we'll perform that are diagnostic are basically endoscopic, radiologic, manometric, and a few others. So the special investigations that form the basis of our diagnosis would be a chest radiograph, a barium swallow, a CT scan, MRI, a rigid or a flexible endoscopy, and there are a few recent advances as well that I'll be discussing later on. So, what are the evaluation techniques? So, these are the basic tests that are specific for our dysphagia, and these are commonly done by radiologists and a newer domain, which are the people speech language pathologists. So, the bedside swallowing evaluation and an endoscopic evaluation, then a barium swallow or a modified barium swallow study, and then fiber optic endoscopic evaluation of swallowing fees. So, what is a bedside swallow test? It is basically as simple as it sounds. It's a patient is asked to swallow different consistencies of fluids and foods, and then you have a scoring that if the patient meets the criteria, what score you should give him, and that will help you in diagnosing the degree of dysphagia. For infants, this has a different criteria. We look at the pre-feeding skills, the breastfeeding, bottle feeding ability, and the observation of caregivers. These all things will help us in making a score regarding the dysphagia. So fiber optic endoscopy is very useful when you pass the flexible scope through the nasal passageway into the pharynx and larynx, and you do it before and after swallow. So the fees basically assesses how well a patient swallows, and you can see in real time the vocal cords of the patient, the larynx, the pharynx, and then you can ask the patient to swallow in between, and you can even look at the movement of the cords and the pharynx and larynx structures in real time. Barium swallow is basically the ideal first test we also advise in our OPDs, and it is readily available. It is relatively cost effective than the rest. and it can be rapidly performed. So, a very useful information can be gathered by the barium swallow study. The safety and diagnostic yield of the upper endoscopy are enhanced by the barium swallow. So you can look at this. This is a barium swallow on the left. You can see it's the study shows that it's a relatively patent esophagus, while in the right one you see there's a stricture down below where the arrow is pointing. The modified barium swallow study is basically similar to the one discussed before, but it is modified in a sense that a video fluoroscopy is done and we see in real time while the bolus is flowing down. So it is relatively a newer advancement and it gives us a better modality, and it is you're visualizing the bolus flow through the aerodigestive tract in real time. So you can see this is how a modified barium swallow looks like. The manometric techniques are basically assessing the pH in the esophagus at the sphincter levels, and it is invaluable in assessing GERD, because GERD can be one of the main reasons causing dysphagia. So that is why it should also be considered. Upper GI endoscopy is superior in terms that it allows a direct visual assessment of the mucosa, and it can also be therapeutic because we can perform maneuvers like biopsies, brushings, and annotations. And we usually do this in our department as well. So we know the use of this. So video fluoroscopy swallow study basically is conducted by a team, and then the patient is asked to swallow various consistencies of food mixed with barium, and then we see it in real time during the X-ray. Would anyone like to tell me that if the patient is uh, allergic or sensitive to barium, what should be the protocol? Anyone here would like to contribute on this? Yeah, as told by Dr. Shazan, that then we can use gastrograph. So this is how a video fluoroscopy is done. You can see that we are using the flexible scope, and then the patient is asked to swallow, and we look at that. So let's see a short video of the video fluoroscopy. So this is how the patient is presenting to you. You ask them to take different consistencies of fluids or food, and then you can see on the screen behind that how in real time you can see the movement down in the uh, on the screen. And look at this, that how yeah, the circle over here is showing that how there's a anomaly over here and there's delayed transport of food. So this is a very useful investigation in terms that we are basically dealing with the please, yeah, let me reshare. नहीं, यहाँ से ना मैंने escape कर दिया. Please just wait a minute. Let me reshare the screen. I want to save it. Yeah. Yes, sorry for the glitch. We're back. So now I would like to talk about the patients with Parkinson's disease. They also have some sort of dysphagia. So scoring of SCAS PD is developed for these patients, and it basically involves solely observing the three swallows. So we can also get a PET scan, which is highly sensitive for detecting the carcinoma of esophagus and metastatic lesions in patients deemed candidate for curative resection on the basis of CT alone. So let's talk about the professionals known as speech language pathologists. They have taken over patients and they have extended their services in evaluation, diagnosis, and rehabilitation of patients presenting with dysphagia. They render their services in modifying the texture of food and fluid and reducing the risk of malnutrition, dehydration, and choking in these patients. So this is how they help in basically deciding the what texture of food is better for these patients. So now we have basically discussed the various tests that are used for the assessment of dysphagia. Let's have a quick pictorial glance on the different differential diagnosis of dysphagia so we can better grasp the topic and we can know more about it. So there can be developmental defects in the esophagus, such as esophageal atresia, tracheoesophageal fistula, as shown in the picture. Then there can be an esophageal ring or web that will cause an episodic dysphagia to solid food. The developmental defects also include esophageal diverticula, which will also present as an episodic food regurg, which may be painful. This is how the strictures are seen through the endoscope, and then this is how they're seen on a barium study. So the peritonsillar abscess patients present to us very commonly, and you can see in this image that how they present with odynophagia, which can later lead to dysphagia. So here's a fun fact. Quincy is basically derived from a French word esquinency, which is basically rendered as squincy, and then it became Quincy. So I guess it was just like a game of Chinese whisper. So now this is something that we see very often, a symptom. Patients come to us with the complain of some lump in throat, or they'll say that our food is getting stuck. But when you get do a full screen and you see that everything is normal, that is probably globus pharyngeus. It is an uncomfortable sensation in throat, and it was thought to be a manifestation of hysteria or anxiety. So the extrinsic compressions, we know that it can be seen in CT or MRI, and they can be malignant masses or vascular anomalies. It can be goiter. You can see in the picture that goiter as big as this can easily be compressing the esophagus. Then there can be dysphagia lusoria, in which we have the external compression of esophagus by an aberrant right subclavian artery, which arises from the thoracic aorta because it's aberrant, and then it courses posterior to the esophagus, causing dysphagia. The foreign bodies we see very common. The children are basically presenting with foreign bodies, and the dysphagia is basically due to the foreign bodies in esophagus. So these are the foreign bodies, they how they look in endoscope. Then a very important thing to know is that the corrosive intake, the patients who present after corrosive intakes would develop strictures, and this is how the stricture would look on an endoscope and then on a barium study. Zenker's diverticulum, mostly in the elderly, you can see there's an outpouching that will also lead to dysphagia. So here's a question for all those who are dozing off, that look at the picture over here and tell me that what can be the diagnosis of this. So I guess you're all awake. So this is Plummer-Vinson syndrome. So in the end, let's talk about neurological lesions as well, because the patients in elderly will be presenting with multiple sclerosis, Parkinson's, dementia, rabies, or dystrophies. So they'll also have dysphagia. And in these patients, we'll look for MRI findings as well. GERD, a very common thing in our society, and that can also be a reason of dysphagia. Hiatal hernia. You can see in this picture over here how a herniated portion of stomach is basically causing the pressure on esophagus and causing dysphagia. So let's also talk about cervical spondylosis, in which osteophytes are formed, and then these osteophytes you can see labeled in on the yellow arrow in between, that it can be obstructing the esophagus, exerting pressure and causing dysphagia. In the end, we also know that the carcinomas we deal in our head and neck are basically the reasons that are basically the obstructive reason of the dysphagia. There are mostly squamous cell carcinoma and the risk factors we know for this disease. So we also need to know that the anxiety and depression can also lead to dysphagia, which may be psychosocial. And you can see in this picture that how the neurodevelopmental changes and the different neurotransmitters can lead to symptoms like dysphagia. So lastly, I would like to tell you about some new recent trends that are usually performed internationally. Uh, and these are intraoperative neurophysiological monitoring, in which the patients are the nerves are checked intraoperatively to protect them while we are performing surgeries that are involved in swallowing. Then there's neonatal feeding assessment scale, which has six different subsections, and we see them, and then we basically form a score. Then there's functional luminal imaging probe flip. It is a technology which employs a catheter to measure the esophageal dimensions, pressure during swallowing, and it helps to assess the esophageal function, identifying conditions like achalasia, motor disorders affecting swallowing. The MASA basically is a man assessment of swallowing ability. It has four components. We look at the general examination, the oral phase, the preparatory phase, and the pharyngeal phase, and the scoring of 5 to 10 point is done. This is basically done by the speech language pathologist. Endoscopic ultrasonography is basically an emerging diagnostic modality. It permits the characterization of esophageal masses, the lymphadenopathy, the endoscopic fine needle aspiration biopsies. So these ultrasound guided biopsies will help us in the cases that such as carcinomas. So in the end, I would like to ask you all to look at this flowchart that we made. It is basically helping us to know to direct our way in patients that present with dysphagia. So it is very useful. We have already discussed it, but it is just a quick recap of how we should deal with patients that present with dysphagia. So you should look for mechanical obstruction, or you should look for neuromuscular disorders. Then it may be intermittent progressive. You should rule out chronic heartburn, chest pains, and respiratory systems, and then they will basically help you pinpoint the diagnosis so you can evaluate whether esophagoscopy or a barium study. So, in the end, I would like to thank you all, and I would like to finish with a quote that basically life is like a sandwich, and you must fill it with the best ingredients. So, with this thought, I just shared this quotation because we as ENT surgeons can make the life of patients with dysphagia better. So let's all commit and vow to make their lives better by knowing how to assess dysphagia. So thank you very much. Now I would like to request Dr. Solid to please comment on the radiological assessment of dysphagia. उस पे करना है इस पे करना
Bismillahirrahmanirrahim. Assalamu alaikum. Thanks for inviting me. Uh, Regarding imaging modalities for evaluation of dysphagia, the imaging modalities which play important role include X-ray, soft tissue, lateral view of neck, barium swallow, CT scan, MRI, and endoscopic ultrasound. However, selection of imaging modality depends upon the suspected etiology and also the site of dysphagia. First of all, we will read about X-ray soft tissue lateral view of neck. ये आपने अक्सर एक्सरे करवाया भी होगा. This X-ray is indicated when there is dysphagia at the level of neck. तो इसमें जो सबसे इम्पोर्टेंट चीज आपने देखनी है, सबसे इम्पोर्टेंट पॉइंट है, that is prevertebral soft tissue. The prevertebral soft tissue thickness varies at these two levels. From C1 to C4, it is approximately 3 to 4 mm. Thank you. From C1 to C4 level, it is approximately 3 to 4 mm, and below the C4, that is C5 downwards, it should be less than half of the dimension of adjacent vertebral body. So if it is less than half or is equal to half of the AP dimension of adjacent vertebral body, it is normal. But when it is more than half, it is suspicious. And when it is more than AP dimension of adjacent vertebral body, it is abnormal. So the next thing we have to see, there is presence of any abnormal lucency or opacity within this prevertebral soft tissue. This prevertebral soft tissue is basically the prevertebral space as well as retropharyngeal space. When any abnormal lucency is present in this part, it means that is air and most likely an abscess or perforation. And when there is abnormal opacity in this part, that may be a foreign body. We must be familiar with the normal opacity, that is a cricoid cartilage. These laryngeal cartilage are normally calcified with age. So this is a normal X-ray soft tissue lateral view of neck. Now here is the abnormal. You can easily appreciate that the prevertebral soft tissue is thickened. It is more than the AP dimension of adjacent vertebral body, and also air lucencies are present within it. So this sort of X-ray suggests abscess in prevertebral or retropharyngeal space. Mainly the retropharyngeal abscess is the diagnosis of this X-ray. Another case, again, we can see that there is prevertebral soft tissue swelling in upper level. Here it was expected to be 3 to 4 mm, but it is thickened. Again, air lucencies are seen within it. So again, a case of retropharyngeal abscess. Another case in which we can see that the prevertebral soft tissue is thickened starting from C5 downwards, and it is more than half of the AP dimension of adjacent vertebral body. So this is a thickened tissue. As patient is old age, we can see there is a filling in the most of the teeth, and she also presented with dysphagia. So most likely suspicion or diagnosis is of post-cricoid CA. When we see thickening of prevertebral soft tissue, next we should also see the vertebral bodies to rule out any vertebral etiology of this prevertebral swelling. For example, collapse of the vertebral body or discovertebral osteomyelitis. Now the normal barium swallow. Dr. Sama already shared with you the technique of barium swallow. I will share some slides showing normal anatomy of the barium swallow. After giving a bolus of barium under fluoroscope, we first of all monitor its passage from the oral cavity into the stomach through the esophagus. There should be no holdup during this passage. And after this, we take spot images. While patient is swallowing, we take AP and lateral view of cervical esophagus. And next, we take AP and oblique view of thoracic esophagus. Back हो जाएगी? No? Okay, there are a certain impression in the barium swallow on the esophagus, and we must know about them because we should not take it as a pathology. For example, the more persistent impression is that of aortic knuckle in the thoracic esophagus. Next is the impression due to left main stem bronchus. It should not be taken as a pathology or compromise of lumen. Next comes the impression due to left atrium. It also causes indentation on the esophagus and it is a normal anatomy. Now some pathologies of barium swallow. Whenever we see a pathology, we must first of all make sure that it is a pathology. It is not, it means it is a persistent finding. If we are seeing through fluoroscope, it should be persistent throughout our study. And if we are provided with X-ray films, then this finding should be present in all films, in all projections. Then it is a persistent finding, and then it is a pathology. Otherwise, sometimes peristalsis also appear as a narrowed segment, but that is transient. It will not be present in other images. So first of all, we should see that the finding is persistent. Then for evaluation of this narrow segment, we should see at least 3 points. First point is that the length of the segment. If the length is short, that the differential is between mitotic lesion and peptic stricture. And if the length is long, most likely diagnosis is corrosive stricture or stricture due to radiotherapy. Number 2, we should look about the mucosa. This is lumen and this is mucosa. The mucosa is normally smooth, but at this level we can see that the mucosa is irregular, eroded. So eroded, irregular, speculated mucosa indicate a malignant process. If the mucosa is smooth, it indicates a benign process like corrosive stricture, peptic stricture. Third is transition from normal to abnormal caliber. If this transition is abrupt, it indicates a mitotic process. If the transition is tapered, it indicates a benign process. So there are 3 points we should look for in a case of stricture. Also, the site is very important. For example, we know that the corrosive strictures are commonly in thoracic esophagus, peptic stricture is in distal esophagus, and the mitotic stricture may be at any place. Webs are prominent in cervical esophagus. Again, the case. In this barium swallow, we see a stricture. Now you will tell me it is a benign stricture or malignant. Malignant. Which are what are the features favoring malignancy? Yeah, exactly. Short segment, mucosa is irregular, and the change of caliber from normal to abnormal is abrupt. So this is a malignant stricture. Another stricture in this barium swallow. Where is stricture? Yes, in distal thoracic esophagus. What about mucosa? So it is a benign. Good. All 3 features favoring benign. And this is a common site for peptic stricture because gastroesophageal reflux is a common cause of peptic stricture. Usually in such cases, we also see associated hiatus hernia, that is intrathoracic protrusion of part of stomach, which causes repeated reflux. Now, in this case, we see a long structure involving thoracic esophagus. So margins are tapered, mucosa is
Uh, Everyone, there's a glitch. We'll be reconnecting in 30 seconds.
Check. Say, should I say?
वो भी चल नहीं रहा हूँ, दोबारा सुना। Yes. नहीं, वो भी आज फिर ऐसे ही कर लेते हैं।
क्या करें?
क्लोज करके फिर आना पड़ेगा।
अच्छा।
We'll be reconnecting shortly. Please wait. वो स्क्रीन शेयर करो वहाँ से, यहाँ से पहले रिकॉर्डिंग है क्या? वो मैं कर
मैंने उधर ही जहाँ वहीं से स्टार्ट करें जहाँ पे हमारा रह गया था। अभी डिस्प्ले में आ जाएगा। So regarding eclasia, I was just mentioning a point that commonly we see primary ecclesia, but we should differentiate it from secondary ecclesia, which is due to some malignant pathology at this junction. In that case, there will be indentation by soft tissue at this level, and also the mucosa will be irregular. So first of all, mucosa should be regular, smooth, tapered, narrowing should be at gastroesophageal junction without any indentation on dilated part. Regarding soft lateral view of barium swallow, this is the pyriform fossa, this is valliculum, and here we can see some minor indentation. Here we can see some minor indentation, shallow indentation on anterior aspect of cervical esophagus, and these should not be confused for webs. These are basically the venous plexus. These are the venous impression, and these are transient and very shallow. In this case, we can see a thin and shelf-like anterior indentation on the cervical esophagus with proximal dilatation and holdup. This is a typical case of esophageal web. Sometimes web may appear as an oblique filling defect. This is very thin, but it is an oblique and complete filling defect with proximal holdup. So this is cervical esophagus is a part which should be evaluated always very carefully to so that we are not going to miss any web. Web may appear as a circumferential ring causing filling defect and proximal holdup. And finally, a case in barium swallow in which we can see prevertebral soft tissue swelling that the it is more than the AP dimension of adjacent vertebral body, and there is abrupt luminal narrowing with mucosal undulation and irregularity, proximal holdup within the piriform fossa and valliculum. So this is a case of proskiricoid CA. Barium and endoscopy are the studies which help us to evaluate the lumen and mucosal outline. But when we want to see the wall, and outside the wall, we go for ultrasound, endoscopic ultrasound, CT scan, and MRI. For example, in this case, we can see a growth in a subdermal soft tissue in postcricoid region and with obliteration of parapharyngeal spaces, this and compression upon prevertebral muscles. So this is a postcricoid CA. CT is also helpful for evaluation of local staging as well as cervical lymphadenopathy or associated lymphadenopathy, and also for distant metastatic deposit. CT scan of the same patient of pre-post-cricoid CA. Thank you. So,
Thank you very much, Professor Solar. And Osama, it was very good presentation. And thank you very much, Professor Tahir Rashid. Tahir Saab is, mashallah, very skillful and highly learned professor. He's with us in this morning session. So now the topic is open for discussion. As you know, the topic is the assessment of the dysphagia. So I'm seeking the input from Professor Tahir Rashid. Sir, can you please guide our residents? What is the list of investigations? Suppose if a patient present with complaint of dysphagia and you examine the patient, suppose I am presenting a scenario, an old patient having history of dysphagia for solids and liquids, and you examine on fiber optic laryngoscopic examination, there is a pooling of saliva. Now, how you proceed this case?
Thank you, Professor Safraz and Usama. You have explained the dysphagia very well, and Dr. Solet has given us the insight how to investigate the dysphagia. For this scenario, I think first of all, the history is important, whether it is a gradual onset or abrupt onset. Abrupt onset, acute onset means there is some foreign body, and gradual means there is some uh, obstruction in the esophagus which is going on for the last many years. And in elderly patients, it is very difficult to find out because most of the time you will see these elderly patients, they are having, they are edentulous, they have caries teeth, they are unable to chew the food very well. And sometimes they take this meat and are unable to masticate the meat, and they swallow that as a whole. That can cause dysphagia. The other thing is that arthritis. Sometimes these people are having a lipping of the cervical spine or there is a different curvature. This lateral view of the uh, neck, that is not also that is not only important for the presence of foreign body, but you have to see the curvature of the spine also, because if you are going for the endoscopic examination, especially for the rigid esophagoscope, these are very important. There is lipping of the vertebral bodies and the curvatures that will not allow you to even. Okay. The other thing is that uh, in that case, if there is a pooling of saliva, you should go for the endoscopic evaluation of that patient first. And this, I will prefer in elderly, I should go for the flexible one first, and that will help us. If that is not possible for some reasons, then you can go for the rigid esophagoscope, and that will explain the why there is a obstruction in the lower down. For the young slot, always look for the dental caries, dentulous position, and in elderly patients, as you Usama has said, 22% of the people who are more than 50 years of age, they have some sort of dysphagia. That is true, and that is related to the aspiration, because 80% of the people after the age of 50 they aspirate, and during aspiration they have some form of dysphagia also. So in elderly, I think we should incorporate the neurology also. If you cannot find a obstructive lesion, involve the neurologist, and this in coordination between the swallowing, that as there is a incoordination in the muscles, so that can lead to dysphagia also. Thank you, Sarfraz.
Sir, my next question is, suppose a patient, old age patient, and there is a suspicious of neurological lesion. So in such situation, you will directly involve the neurology or neurologist colleagues, or you will like to do exclude some other mechanical causes. Suppose the patient has absent gag, there is a aspiration. So this is the clear-cut case of neurology, and so we refer this patient to neurologist, or we can help in restoring the food pipe like some maneuver.
I think speech language pathology, they can help. They can advise the patient which sort of which consistency patient should take, because this is a neuromuscular disorder, and in which sometimes people, they have dysphagia for the liquids, and they are able to take the semi-solid or solid foods. So speech language pathology will help the consistency of the food, and again neurologists, they will help us for some medication which can be better for the coordination of the muscles.
Thank you very much, Professor Tahir.
And
Sir,
welcome.
a few days back, a patient presented to our department with a history of bolus infection, and our resident removed the bolus. So, do you think in these patients who has history of infection, they need some investigations, or the treatment is over when we remove the bolus?
If it is
What do
for
you
the
think, sir?
first time, this is for the first
Sir.
time.
Sir, yes, sir.
In that case, you don't need further investigation. Remove the bolus. That can happen to anybody with the food bolus or with the bone. But if the patient has a history of food sticking in the previous years, then we should investigate the uh, patient for the flexible endoscopy later on and for the fluoroscopic examination of the swallowing. That can show us some incoordination or neuromuscular disorder if there is no obstruction. As there is no obstruction, the patient is having a occasional history of obstruction, but for abrupt onset, you don't need any investigation further.
Okay. Thank you very much, sir.
Welcome.
Another learned professor has joined us, Professor Khalid Chima, sir. Sir, if you are online, so can you please give some tips regarding the management as a concluding? Then I will come back to the Professor Tahir Rashid. Yes. नहीं? चलो फिर मेरा ख्याल खत्म करेंगे. सर थैंक यू वेरी मच प्रोफेसर ताहिर. आई एम सॉरी कि आज की मीटिंग में हमारे कुछ नेट के ग्लिचेस थे. इंशाल्लाह विद द पैसेज टाइम वी विल इम्प्रूव.
Yeah,
एंड
inshallah.
थैंक यू वेरी मच, आपने हमें ज्वाइन किया.
Thank you.
और
Thank you.
सो अगर आप सम अप करना चाहें regarding the topic, so you're welcome, sir.
Sum up is this: detailed history is important. Take the history because history will tell you 90% of the cause of dysphagia, and you don't need to go for the sophisticated investigation. So after history, examination starting from the oral cavity. Start from the oral cavity. I have seen young patients who are having this caries teeth and dental pain. They are unable to chew the food properly, and they take bolus without chewing that one, and sometimes the food stucks, even in the young patients. So oral cavity is very important. This is the first phase of the swallowing. That is very important, in which the food is masticated and a bolus is soft bolus is made. If that is okay, then comes the obstructive element lower down. First of all, consistency of the bolus. So examine oral cavity, oropharynx, hypopharynx properly. You will find out the cause there. And if there is no pooling there, food can go very well down there. So history, examination, and then go for the investigation and do in non-invasive investigations first, rather for going the rigid esophagoscopy. Barium is okay, and then you can go for the uh, flexible esophagoscopy. Later on, you can go for the rigid one if you need some biopsy or you have to do some dilatation of the some structure. Thank you.
Thank you very much. Thank you very much, Professor Saurabh, for joining us. Thank you very much, all the participants. Meeting is over. Thank you.